So we have quite a few questions. We'll try to get through as many as we possibly can, and when possible, we'll try to keep the answers direct. A question for Dr. Viana. Is multivisceral transplant for pancreatic neuroendocrine tumor appropriate in MEN1?
Oh, appropriate what?
For MEN1, for multiple endocrine neoplasia.
I don't know. I don't think we haven't. The problem with the transplant is that, you know, there's certain regulations to include patients on the list. So you can't, a lot of the neoplasias that potentially you could use it. For example, people are starting to do liver transplant for colon cancer, and you know, you're going to have to do living donors for a while until you prove that works. So it's not appropriate at this time. So.
Okay. Question for Dr. Howe and Dr. Wang. Is there a role for cytoreduction in patients with a Ki-67 greater than 20, and another question greater than 50%?
You know, generally in high-grade tumors, the survival isn't as good, so many would argue not to do that. I think there's a big difference between 20% and 50%, and I think in 20% you can make an argument. Yizar?
Yeah, the 20% usually is my cutoff, but in a case-by-case, young, healthy patient and no other better options. So the 20, 25, I still try to give it best shot if nothing else is working. But beyond that, I think, you know, the better choice will be chemo or something else.
Okay. Are there any treatments that you would do that would preclude PRRT definitively? Various types of stereotactic body radiation of the liver, or embolization of the liver past a certain point with radioembolization? Are there any absolute cutoffs that you would see?
There's no absolute cutoffs, but with the exception that if you can estimate the amount of normal liver that has been compromised by radiation, and there is not at least 700 cc's of normal liver with good perfusion, and I go over that with our liver surgeons and our radiologists very carefully, because you can be fooled if they've been heavily treated with other agents. But to the best of your ability, if you can determine that, if they would have been a surgical candidate, obviously they're not, but by volume, then we're much more comfortable treating if the tumors you're treating are not in that 700 cc's that you're maintaining the patient's survival in. So the absolute cutoff would be volume, but we don't have enough data to know if the frequency of treatment or the dose of treatment has any impact beyond that.
Right. Now I have three questions addressed to Dr. Howe. One, when would you refer patients for liver transplant? And number two, how do you feel about lymphatic mapping and Chinese dumplings?
We don't refer many patients for liver transplantation, but clearly, listening to Dr. Viana's talk, I mean, there seems to be a role for that. There are some people that we just can't help with debulking who have extensive disease, but they have to have no extrahepatic disease, and that's rare, especially now with DOTA PET scans. We're finding bone mets and other sites of disease. With respect to lymphatic mapping, I commend Yizarn for taking a tool that's been used in colon cancer and extensively for melanoma and applying it to these patients. I personally don't use it, and I would say Yizarn's probably the only guy who does use it that I know of, but maybe Yizarn can comment on that more. I think I can identify, you know, the lymphatic drainage of most patients without using the mapping, but again, Yizarn has strong feelings on this.
Yeah, to me, as I illustrated, I just don't think, you know, human eyes can determine where the tumor stops, where the tumor begins. So I think, you know, something can at least help me identify, and I don't have to second guess, say, am I doing the right thing or I'm doing the wrong thing today? You know, so that's why I insist that's the way to do. And plus, there's a couple of times that the lymph node was in the outside resection boundary, so to speak, I would never imagine the tumor will go in that area and end up just show up. Plus, the resident in the room operate with me, they always ask me, say, Dr. Wang, where should I cut? You know, how you know? I say, well, just follow the blue line. You know, so much easier.
Okay. Here's a question, I guess, for Dr. Viano. What is the role of doing lung transplants for lung carcinoids? And would you use a nano knife on a lung?
I think, except for the group in Toronto in Canada that's now addressing some of the cancers, the role has been to resect because it depends where the tumor starts. If it's primary from lung, I think most of the times people have been able to resect or even do like an ex vivo therapy. We have not done, I think, in the US a combined transplant with the lungs, although we have a candidate around that might get a multivisceral lung transplant, but I don't think it has been done yet if you have multiple, because usually you can try to resect.
Okay. Dr. Howe and Dr. Wang, with a 40% hepatic resection when the liver regrows, how is the regrown part different than the original liver? Dr. Howe, what would you say?
Well, I mean, we talk about liver regeneration, and I'm not sure how much of it's regeneration versus hypertrophy or enlargement of those cells. And some people have asked the question, if it grows back without tumors, right? So that's a good thing. I'm not sure how to answer this question. I mean, it regrows by regeneration and hypertrophy.
The other thing we take into account is the native liver's condition before we operate on those patients. If someone has a cirrhosis, they may not have a capacity to regenerate to the way they should be. So like for the chemotherapy people, if someone already had a chemotherapy up front, those liver may have a good quality to regenerate. So we do take those into account. If someone has a cirrhosis, someone had a previous chemotherapy, we do give a little bit more cushioning to make sure we don't screw up the patient. Plus, I said, you can tell from my passion, I personally don't think there's a formal indication for formal resection for carcinoid or neuroendocrine tumor for liver mets. They always come back. So you really should focus on remove the disease only and spare the normal parenchyma. So save the money for the rainy days.
Okay. Question for Dr. Kennedy. Would transhepatic chemoembolization be an option after receiving radioembolization and vice versa?
Well, you've hit on an excellent point there, whoever asked the question, because of the oxygenation that we need. We definitely would not want to closely put these two treatments together. So in the case of doing TACE first and then doing radioembolization, as long as the interval between has been long enough for new blood vessels and reoxygenation, which we often see, patients that come to see us have had a TACE procedure, and that some months later it either was less effective than we hoped or there were new tumors in that same general area. We know that radioembolization in that instance is just as effective as if they had not had TACE before. Conversely, if radioembolization is not an option to retreat new disease, and sometimes that's the case due to liver injury or blood vessels not getting there as safely as we'd like, then adding TACE after has been done successfully and safely. So I think the main thing is the sequence. You wouldn't want to do them too close together because they would inhibit each other, but also the increased risk of complications.
Thank you. Okay, Dr. Viano, what is the youngest patient you have ever treated with multivisceral transplant?
3-month-old baby. He's 15 years old now. So.
Wow. Okay.
Not,
Clearly no age
with,
cutoff.
not with neuroendocrine tumor, though. He was born without intestine and he had liver failure, but 3-month-old.
Okay, question for Dr. Howe. Question on the future of using high-intensity focused ultrasound to eliminate liver metastases.
I don't know much about it.
Or anybody else who has experience with this modality.
I don't personally have experience with HIFU, but in the radiation oncology literature, there are a number of studies now comparing in early for prostate, for other body sites using HIFU, and it's pretty early to tell what the toxicity difference would be, but there is clearly literature that shows that you can ablate tumors of certain sizes with HIFU safely, but I'm not aware of any ongoing liver HIFU trials.
Okay. Dr. Wang, is anybody working on designing an artificial ileocecal valve?
No, but I did try it a few patients. When the patient lose it, I ended up inverting the intestine and make an artificial valve we call nipple valve. And as one of the patients I did at VA only have a 60 centimeter intestine left, I put a 3 inverting nipple valve into it. But a funny story, he after surgery he disappeared for 3 years. Then one day he called me. He said, "Dr. Wang, you need to help me." I said, "What's going on?" Before I did involve the valve, he was making valve function about 24 times a day. He cannot get hold of a job, so he got a VA disability pension. And I did those valve. Ended up he can hold a job, and he did not return the money to the VA. So the VA finally find out he was double dipping. He was getting pension and also get disability, and he was holding a job. So he called me back, say, "Can you write VA letters, say I'm still disabled?" I said, "I'm sorry, Ted, I cannot write for you."
Okay. We have a question about whether, well, just, I guess, a statement that there is a study going on at the NIH on familial carcinoid. And I guess everybody should be aware that Dr. Stephen Wenk at the NIH is doing such a study and provides gallium scans and fluorodopa PET scans for people who have this disease. But it's an interesting statement to be aware that we have it, and also Dr. Howe has a particular interest in familial endocrine tumor syndromes, and you may want to comment on that.
Yeah, the NIH has a lot of resources that comes from the taxpayers where they've done some really nice studies to look for genes for familial carcinoid. And I think from one of Dr. Warner's families, they were able to identify a gene just last year. Unfortunately, only one family out of the 22 or so or 35 that they studied had that gene. We're also at Iowa, we have a collection of about 13 to 15 families with multiple affected family members where we're doing exome sequencing and looking for additional genes. So if people have multiple affected family members, we can't offer DOTA PET scans free like the government can or flying you out to Bethesda, but we're interested in looking for genes that are responsible for that.
Thank you. A very important issue. It is relatively uncommon, but it may be more common in the population than people appreciate. Okay. Why is nanoknife used only for 2 centimeter or less tumor sizes?
There's a technology limitation. You need to have put a probe close enough to generate enough the lightning effect. The nanoknife basically is lightning, and try to hit small holes on your shingles on your rooftop, and without burning your house down. And hopefully enough hole on the shingle, enough water seeping through the house, eventually 6 months later the house collapsed. But in order to make the small single holes on your shingle without burning your house down, you need to put the two probes close enough together to generate very, very high frequency and low energy burn to your shingle. But if you're too far apart, it just never work.
Does removal of a primary tumor increase the blood flow to metastasis?
Not that I can conceive of. Are you talking about liver metastases?
That's
Or nodal metastases? Yeah,
I don't think so. Okay. There's some interesting thoughts about the effects on liver metastases when a primary is removed. I'm not sure how well that's been established, but conceivably you can reduce output of certain growth factors in the portal vein. I don't know if either of you have any strong feelings about that.
Well, I have some strong feelings. I mean, there's no good studies, again, retrospective studies that have shown survival benefit for removing the primaries. Probably the best study that looked at that was Rod Pommier's group, looked at 60 patients who had 60 patients who had the primary removed and liver metastases left in place, and then 24 patients who did not have the primary removed. And there were comparable groups in terms of degree of liver metastases and not having them resected. And there was a clear survival benefit. There's also a study from Scandinavia, Hellman's group from Uppsala, that showed that, but again, it could have been biased towards people having resection, having less disease. And then there was a UK iNETs trial that just came out a few years ago by Ahmad et al. That showed that on multivariate analysis that removal of the primary in the setting of metastatic disease was one of the most significant factors for survival. So again, these studies are limited by selection bias like we talked about earlier, but the way we think of it, and Dr. Odoricio likes to explain it, is you're turning off the spigot for tumors that are seeding the liver, and that's eventually what people die of. So if you remove the primary tumor, our hope is that you're reducing liver metastases. John?
Okay.
Well, as I say, you need to get the bin Laden out so, you don't send more training camp and send all the bad guys to do bad things.
If someone has bone metastases, should radiation therapy be used for treatment, Dr. Kennedy?
Boy, there are, that's such an individualized question. It's easy if the bone metastasis is either going to cause an impending problem, such as in a weight-bearing bone in the femurs or in the spine, causing compression on nerves. But it's often a question of my patients where we have multiple ribs or other bones for which it's not causing a problem, it's near critical organs, and it's not life-threatening. And there is some disappointment when I say to them, I really don't think it's worth your time to get those irradiated unless they start to cause a problem. So there are certain areas where the bone metastases are present that we prophylactically or presumptively treat them to prevent a problem, but otherwise it's more symptomatic. There's no indication that comprehensive bone irradiation impacts survival.
Right. It's generally thought that carcinoid tumors and well-differentiated tumors don't respond very well to radiation, and they're so-called radio-resistant. We know that it's not absolutely true. We certainly treat with PRRT, and we can treat with radiation therapy, resulting in pain relief and prevention of fracture, and it certainly has a role. But radiation with external beam is not done as a routine. As Dr. Kennedy said, it would have to be really individualized depending on the issues. Is that fair?
That's correct, and possibly the reasons why it was thought to be less effective, external beam radiation, is in the bad old days, we didn't have sophisticated ways of targeting. We also had limitations on the technology and the energy delivered, and with a lot of that accounted for, we were underdosing these lesions. When we are able to give the right dose very carefully to the tumor, there's no radiosensitivity difference in neuroendocrine tumors to colon tumors to breast tumors. So you have to give enough dose safely to it.
Okay. If a high-grade neuroendocrine tumor patient has chemotherapy and is responding, but has some tumors remaining in the liver, at what point would you do embolization treatments to the liver, despite the fact that it is high-grade? Or would you?
So the absolute yeses are symptomatic from either secretion or stretching of the capsule. In asymptomatic patients, we look at pace of disease and how much extrahepatic disease there is. If it's liver dominant and we are worried about the pace of disease, then we would treat even if they're asymptomatic to try to get ahead of the curve, so to speak, on aggressive disease.
You may want to ask Dr. Anthony about this question this afternoon, and he and me talk is a personal communication. It's not published or anything. His theory is that he's a tumor, sometimes a mixed bag of different differentiation tumor, and so the chemotherapy may be very effective to kill all this high-grade tumor, and some of the intermediate low-grade tumor left behind, and those can be treated either with radiation or with a surgery or something else. So she's very excited about this new concept, say maybe sometime a combined therapy will be important. Use a chemotherapy to knock out the high-grade tumor, and then the surgeon or radiation oncologist, to go back to map up, to finish up the residual tumors.
That's true. it has to still be individualized with patients because there's always a risk the high-grade component will grow back faster. One of the things about well-differentiated neuroendocrine tumors is they usually are not a mix of truly high-grade and truly low-grade. It's really something that Ki-67 might increase over time from 3% to 17%, but it's not going to suddenly turn into a high-grade neuroendocrine tumor with a Ki-67 of 95% and start growing like crazy and can only be treated with intensive chemotherapy. That kind of transformation does not usually happen. But certainly there could be some sites of metastasis which are more resistant and need to be treated with another modality. Okay, this is a question here for Dr. Wang. Is the pancreas, if you have a neuroendocrine tumor in the pancreas, is the mesentery closer to the tail of the pancreas or the head of the pancreas?
Depends on the tumor where the location of the pancreas. If the tumor is toward the head of the pancreas, yes. And like the case that I showed with a celiac trunk involvement, those become very difficult cases. But the tumor toward the tail of the pancreas is usually not a threat at all.
Okay. Dr. Viana, how common are MVOT complications or failures due to thrombosis or stenosis at the anastomotic site?
Thank God it's very rare. Those are big anastomosis. When we take all the organs, they come in and block. So we put the aorta, which is a very big vessel, to the aorta of the recipient, and the vena cava, very close to the heart. So the difficult part of the multivisceral is the resection. The implantation, it's a little bit easier because you already remove all the organs. So it's almost unheard of to have a stricture of the vascular anastomosis on multivisceral transplantation.
Okay. A question, who does embolization therapy? A radiation oncologist, an interventional radiologist, or a surgical oncologist?
Oh, that's an easy one. The surgical oncologists generally do not. It doesn't involve a knife, so they're out. About half of the centers in the United States, the main or authorized user is an interventional radiologist. It fits into their scope of practice. There's a special certification they can get from the NRC and the FDA. And the other half are centers that have the contribution of a radiation oncologist who's the authorized user to use the radioactivity. Most of the centers that are the busiest and the longest running have a multidisciplinary approach that even though the interventional radiologists are very comfortable doing it, there is great benefit to having collaboration, and so many of the cases, or most of the cases, have input from the radiation oncologist, if not actually helping deliver it. But that's the US model. In Europe, it's a little different because radiation oncologists and medical oncologists are sometimes one and the same, and their interventional and nuclear medicine physicians have a more prominent role. So in Europe, it's much more interventional radiology driven than it is in the US. Didn't mean to slight my surgical colleagues.
For individuals who have an adverse reaction to intravenous contrast, what sort of scan should be done?
Well, if you're looking for liver, I mean, MRI is a great way to image the liver, probably better than CT. Although the advantage of CT for most of our patients is it shows recurrence of lymph nodes and things of that nature much better than MR does. But MR is definitely better for the liver.
Right. I would say an MR with especially EOVIST contrast gives beautiful pictures of liver metastases, even extremely tiny ones. And diffusion techniques and other special techniques with the MRI can give amazingly good pictures, resolution of liver metastases down to the same range as you actually get with gallium-68 and PET scanning. It's remarkably good. And as we heard, the imaging the rest of the abdomen is a little bit more difficult with both CT and MR. With the best techniques, both MR and CT, I would say, are really excellent. And in certain situations, one might be better than the other. Okay. Another question, Dr. Howe, after a major liver resection and radiofrequency ablation, what type of follow-up is appropriate, and when would you use embolization therapy in the future?
So our general practice is we do the ablations and resections, and then we'll check a CT scan in about 3 months. We know that our interventional colleagues, when they do percutaneous ablation, they'll often check in at about a month. But we'll do it about 3 months and get a new baseline, and then we do it every 6 months after that. Embolization would be reserved for down the road when there's progression. We favor PRRT over embolization in many cases, but there certainly is a role for it. But again, we wait for there to be significant progression.
Okay. How about a yes or no answer on this one for Dr. Wang? Would using immune checkpoint inhibitors mixed with 5-FU put into the abdominal cavity be better than 5-FU?
What's the trial? I said, was to give it a try.
Okay. What did you say, worthy to give a trial?
Yeah.
Yeah, I mean, that's a complex issue. Okay. Can blue dye be used for mapping resections for lung carcinoids?
The chest surgeon has been using that. I don't know if they had adopted for the lung node yet or not, but at least our group for the regular lung cancer, for a while they were trying that.
Okay. After multivisceral transplant, what is the loss rate for rejection or infection?
Yeah, it's interesting that when you get a multivisceral transplant, the liver has a very protective effect over the other organs. So multivisceral rejects less than the other organs. Like if you transplant the organs individually, a pancreas or an intestine, you have a lot more rejection than if you transplant them en bloc. So the rate of rejection is about 10% in multivisceral, but rejection doesn't mean you're going to lose the organ, right? Rejection means that we're going to have to treat it. It's rare to lose a multivisceral graft these days due to rejection. What happens is that with the techniques that we have now, we lose patients to other disease, like either we push it when the patient is too sick and he doesn't have the body doesn't have the reserve to go through that operation, he can recover. So rejection has been under much better control, and that's why the results have improved so much. Also, the surgical technique has improved. The infection, it's about the same as the other organs because we have reduced a lot of the immunosuppression. And I think in every organ that we transplant, usually patients die from infection if you have multiple episodes of rejection. And then you keep treating them until the immune system is not very strong. So again, about 10% of the patients will die within a year of a multivisceral transplant. It's either related to one of them, but rejection is quite rare in multivisceral transplant.
Okay, next question is an excellent one. I understand that Whipple patients should not have embolization to the liver due to a problem with bacterial infection. And the question is whether this is true and whether patients who would end up having liver directed treatment later should have antibiotic prophylaxis and whether it should not be done at all. I think is a very interesting question.
So I think there's a lot of misunderstanding in that area. It's certainly done every day. It's whether it's radioembolization or bland embolization can safely be done after a Whipple. The precautions of bowel prep and antibiotics are recommended by the interventional radiology team based on their experience of preventing abscesses. I was part of a retrospective study among 4 institutions. We had 1% to 2% infection in over 80 patients with radioembolization with not necessarily Whipple only, but Whipple or anything what they call the violated ampulla, where the interventional gastroenterologist has to incise the sphincter muscle to put a stent or something into the bile duct. So the Northwest group has reported a 30% infection risk even with prophylactic treatment in embolizing patients with violated ampulla, but that's not been reproduced by other groups. So I would say emphatically it is not a contraindication to needed embolization, but certainly precautions are prudent to try to reduce the risk of infection.
Thank you. Do you have any other thoughts about this, Dr. Howe?
Well, I think, this comes up if we have a patient with a tumor in the head of the pancreas where we need to do a Whipple procedure and they have multiple liver lesions, should we do the ablations at the same time? And the argument against it is that you remove the ampulla vater, which is a little nipple valve that keeps bacteria from going up your bile duct. And so when you do a Whipple, there's a connection between the intestine directly to the bile duct, and bacteria can freely flow up there. So if you render tissue in the liver dead, it has a much higher incidence of infection. So it's a hypothetical thing. I think if somebody needs both, it may make sense to do the liver-directed procedure first and then to do the Whipple afterwards.
Okay. Let's move on here. Is hypertrophied liver as functional as an original non-diseased liver would be in the beginning? Who wants to tackle that one?
It depends on the quality of the liver before you touch them. That's why it's very important. We need always have to look at liver function first before we decide how much we're going to manipulate the liver. If someone has a compromised liver to begin with, you have to make a preparation, say the patient may not have a regeneration to the way you like to see.
Okay. Would radiofrequency embolization be an option in larger liver tumors in a patient who has diffuse disease? So you just sort of attack the bigger ones and I guess leave the little ones. Also, after Y90 treatment and systemic chemotherapy, would you use liver-directed therapy at that point, and when would you use it?
It's interesting, there is a lower control probability as tumors get larger, and we don't have a magic number. For Y90, it's been somewhere around 6 centimeters. We start to see a statistical fall off on control with a single application. Not everyone has that experience. So yes, as tumors get larger, we're less effective with any type of embolization. So in patients with dominant large tumors that are not surgical candidates, which would have been our preference, we do something analogous to fractionation with external beam. And that can be fractionation with non-radioactive spheres or with radioactive spheres, where the intent isn't a single treatment and it goes away, but a lesser dose of whichever you're doing, and then do it every 6 to 8 weeks until you eventually get control of it. And the thought process there is, as you kill active disease and there's regression, there's then reoxygenation and new blood vessels, and so you're getting, this is the theory, you're getting access to some of those tumors deeper into the mass that you might not have had access to in a single treatment. But it is a problem. Tumors over 6 centimeters are very difficult to control with any single arterial approach.
Should PRRT be used, or embolization, or somatostatin analogs only if no liver tumors are greater than 1.5 centimeters?
Wow.
Dr. Howe?
Well, we like PRRT, and I think the results of the NETTER-1 trial are going to bear out a very long progression-free survival rate. But for diffuse metastases, certainly embolization is a decent option, but again, we always wonder if the local blood supply is altered by that intervention that might preclude or diminish the effectiveness of PRRT. That hasn't really been shown, but it's a question.
Right. I think one of the really important issues when somebody has multiple liver metastases that are not resectable and they're not more than 1.5 centimeters across is you have to look at the grade of the tumor, the speed of growth, and this whole situation. But in a typical situation where you have a well-differentiated tumor, usually not a very fast-growing tumor, and all the tumors are small, you have to say where you're going to be in 2 years, in 5 years, in 10 years, in 20 years, and you don't want to burn all your bridges and cause lots of toxicity in the beginning that isn't necessary. You want to have quality of life and long life. So my recommendation would be to use a somatostatin analog, keep the situation under control for as long as possible, and even though, for example, the Clarinet trial and lanreotide look like it controls cancer for an average of 33 months, in some people it can control cancer even for 5 or 10 years. There's a large spread in how long it would work, And then one day when things start increasing, then you can say, what is the next step? Should it be PRRT? Should it be another treatment? The other thing to remember is that the NETTER-1 trial was done only in people who had progressed on a somatostatin analog. These are people who had octreotide or lanreotide first in maximal dose, and on that dose were increasing on maximal approved doses. And then PRRT was allowed. And I suspect when PRRT is approved in the United States, it's going to be for a population of patients who have progressed on somatostatin analogs first, because that's where all the data is coming from that's leading to the approval. So I don't think that anybody should run for PRRT right away, even though if you travel around the world, you can always find somebody who would do it for you if you really wanted it. But I don't think that it's really the best thing to do and in your best interest to have PRRT before you've even tried a somatostatin analog when you have multiple small metastases. Does the panel concur? Okay.
Can I expand a little bit on the
Sure.
Chinese dumpling thing? Because Dr. Warren said just answer this question as short as possible. It's a very complicated issue. And I tell you, when I started to do the Chinese dumpling, the hospital tried to stop me. Say, you don't have a research protocol. You cannot put the chemotherapy agent into the abdominal cavity without filing a research protocol. And so I know in my heart it works because we have the tumor, tested in the research lab. The tumor cell will respond to that. In order to file the IRB approved, go through the trial, and that will take me 5 years to get it done. So ended up I have to use I'm using this drug for off-label use. I say I'm such a lousy surgeon, I cause so much bleeding. One of the side effects of 5-FU is it causes thrombosis, thrombogenic. So I say I use 5-FU to help me stop the bleeding. I'm such a lovely surgeon. I got a patient bleed everywhere in the mesentery root, in the liver, after resection. So I use 5-FU to jam into it. And the other question is, can you combine any other therapy into the Chinese dumpling? I thought about that too. So I talked to the second best choice for the chemotherapy from the research lab data. I talked to the manufacturers. So can I use some of your drug to do the test? And so we even thought about to buy a few pigs and to put some Chinese dumpling into the pig's liver to see whether the pig liver will survive or die. And we got everything ready to go, and then finally the company, the headquarters called me and said, we're going to stop that process. I said, why? The company said, if one patient do bad and they sue, the game is over. He said, we will never recover, so they can't the process. We tried to put a second ingredient into the Chinese dumpling, never take off. So it's not that simple. I like the idea. I thought one drug work, maybe two drugs work better, or third drugs even better. But it's not that simple.
Okay. So you're in the operating room. You have lots of liver metastases, mesenteric nodes, different things are in the abdomen. How do you determine if a particular tumor is the primary? Or if you see something in the pancreas and something in the rectum, which one is primary? Are they both primary? How do you go about making that determination at surgery? What would you do?
The primary usually come out either from pancreas or small intestine. You don't have the tumor come out from the lymph node, then grow to the intestine and go to the liver. It just don't go like that. So usually we are pretty certain either start from the small intestine or pancreas somewhere, then go to lymph node, go to the liver. So that's how we decided.
And on preoperative imaging, if it comes from the pancreas, in the vast majority of cases, you're going to see it. A tumor over a centimeter is going to be seen, and there have been several studies that have shown that small bowel tumors, as were shown, are often very small and not seen on preoperative imaging. But when you see these enlarged mesenteric lymph nodes, you know that it's going to be coming from the small bowel. So we usually have a pretty good idea, but it's really the small bowel that are the ones that are the most common sites of the unknown primary.
Okay. And then the second part of this question, can only the surgeon determine the site of the unknown primary, or can it be done by a radiologist or a pathologist? I think it depends on how you look and what is done prior to surgery. In our experience at Cedars-Sinai, when I was there, we were able to identify a primary in 85% of people who showed up with liver metastases and unknown primary. Almost all of them found by endoscopic ultrasound of the pancreas or double balloon enteroscopy looking at the small intestine. I think that it really depends on what studies are being done. There's CT enterography, MR enterography that sometimes can see tumors in the small intestine. There's wireless capsule endoscopy that sometimes will show tumors, although not as accurately as double balloon push endoscopy. And I think, most of the time you could find the primaries. Some of them you can only find at surgery. Some of them you never find. Sometimes pathologists can do special tests that will hint at where the primary might be by immunohistochemistry. There are laboratories like Biotheranostics that sometimes can suggest where a primary might be, but that's where we stand. And there are some patients where no primary is ever found, and they're treated clinically and empirically just based on the where the metastases are and how they're behaving and some of the pathologic features as either primary of the pancreas or primary of the intestine. Most unknown primaries in the abdomen arise from somewhere in the gastrointestinal tract or pancreas, but they may not be obvious in the beginning. And I have seen patients where the primary showed up even 5, 10, 15 years later than the metastases, and it just gradually grew and eventually caused a symptom or something came up that led to diagnosing that. So I don't think there's one right answer to the question. Okay. Dr. Wing, does blue dye flow outward from a primary only, or does it flow in any direction and to any tumor? And can you count on it following the lymphatic system or the blood system?
The blue dye is just to help us to find the cancer escape route. It's not necessary so the cancer is in there. So it's a lymphatic, it's always coming from your intestinal wall, go back to your mesentery, and where the blood supply coming, and that's how they find a way home. So just without the blue dye, you really don't know which group of the lymphatic channel the tumor may be using. But when you inject the blue dye, you may basically map out the cancer escape route, like a bank robber, which street they may be driving through, so you can set a checkpoint to stop those bank robbers.
Okay, this is a question that was addressed to Dr. Viana. If somebody has a urinary diversion from a neuroendocrine cancer of the ileum, and you have a multivisceral transplant, you no longer need a urinary diversion.
Yeah, we have done actually a few patients that we have used part of the, some patients have, even if they lost the bladder, they have a pouch. We have been able either to preserve or to create a new pouch. But I think by here, this is just a comment, it's not related to the question. I think we're not doing a great job coordinating transplantation in the treatment of neuroendocrine tumors. That's very clear to me. What happens is that I think patients are coming very late to transplantation. That's why liver transplantation is not very effective. And actually most of the transplant centers would refuse almost to do a liver transplant because it's too late. So we got to change that. We are burning a bridge, which is a life-saving bridge. And, like a cirrhotic patient that has METs, this is a transplant candidate. You shouldn't even try to resect. He has cirrhosis already. He needs the liver to be replaced. So there's a lot of things that I think we have to do better as a group, maybe multidisciplinary committees, because I think transplantation, you don't have enough organs for everybody. So if you send the patients too late, the transplant centers will refuse to do it. And we are actually taking that away from our patients. We're making this extremely expensive because these therapies are very costly, and we're burning the bridge to the cure. So I think the transplant centers and the oncology groups, and here we have several of them, we need to get together and discuss the indications better, because this can't be, okay, we can't do anything, send them to transplant. That's not going to work. I mean, we have made it work with multivisceral for some cases, but we got to be thinking about how can we make this better for our patients. We're burning that bridge, and that's why the results, most centers will not offer this therapy, which to me is one of the best therapies you can have, because you can actually remove the tumor.
Okay. Dr. Viana, does a bone metastasis on gallium-68 preclude the therapy of MVOT?
Right now it does. So we go back to the same point. We should not be doing that, because you're trying to show that a therapy is effective for neuroendocrine tumor in terms of the cure. Transplantation is not palliation. That's what needs to go away from the thought, from all the thinking. We're not palliating. So by the time, if you're going to do a multivisceral transplant with a metastasis to the bone, then yeah, it is palliation. And we don't want to do that. We want to have a shot in the cure. And the community will not approve because, again, we don't have organs for everybody. So we get to use those organs for the people that still don't have those bone metastases so we can cure them.
All right. My primary was removed from the appendix and ileocecal valve many years ago. 22 years later, I was diagnosed with carcinoid syndrome. Is it possible to find the new primary, and should a biopsy be done if I have lots of liver metastases? Who wants to try that one?
A little confused by the question. So they had an appendectomy and removal of the ileocecal valve?
That's what it says. I'm sure they did a right hemicolectomy at the time, and where the tumor was, I don't know if it was on the surface of the appendix or it was in the appendix. We don't really have any.
So if the patient has carcinoid syndrome, I mean, it could just be coming from the liver metastases. It doesn't necessarily mean that the patient has a new primary.
Right, and that's almost always the case. It's very, very rare that a new primary has anything to do with a carcinoid syndrome, since the clinical syndrome results from the metastatic disease growing in the liver, and normally not from secretions coming from the primary tumor in the small bowel. It's also very uncommon for small intestinal carcinoids to have a new primary in the lung or in the rectum or some other part of the body, since a midgut carcinoid, one that starts in the intestine, is really biologically and genetically very, very different from those that come from other parts of the body. And usually if you're going to have another primary, it would be in the same region as the first tumor was, and again, would not be a cause of the syndrome. So I think that the only reason for biopsying a liver after 22 years is to prove that it really is a carcinoid or a neuroendocrine tumor that's growing in the liver and not some other type of malignancy that might have happened. That would be a normal thing to do, I would say, to be certain of the diagnosis. But I don't think you need to go on another search for a primary if it turns out that there is metastasis in the liver, but rather would just go ahead and treat the liver metastases as appropriate with somatostatin analogs and all kinds of liver-directed therapies or the other things that we talked about. Which raises another question. If somebody has liver metastases, what are the cutoffs for doing embolization? What are the cutoffs for doing surgery? Let's say you have somebody who's on a somatostatin analog and they're progressing, and you need to do something else. Should it be PRRT as the only option, or do you still consider liver-directed options, and what would make you go one way or the other?
Well, I don't think it's that clear in the literature, but we certainly worry when the liver is over 70% replaced that any intervention, and I think you can make some exceptions for embolization, but the patients are at significant risk for hepatic failure, and so any treatment you do could be lethal. So I think when you're up around 70%, you're really rolling the dice. 50%, not so much.
Yeah, I'd agree that the limited literature on over 50% replacement is that above 70%, whether it's neuroendocrine or HCC or colorectal, it's very difficult to protect that 30% because that 30% of, quotes, normal liver isn't really normal. So there's a high probability of liver failure. So 50% is well accepted as a safe, mostly safe intervention. But, and I should point out that that percentage should be done by an actual measurement, volumetric measurement. There are really good radiologists, and I quiz them all the time on what percentage they think a liver is replaced. And 100% of the time they're wrong, and they overestimate by at least 2x. So having the imaging volumetrically measured, which is not hard to do, can often take someone who's 70% replaced and you're actually 40% replaced. Now, neither's great, but to answer your question on a cutoff, I think I would almost never treat someone at 70% replacement for the risk of liver failure.
Now, do you have a cutoff based on size of individual tumors where you say this patient is not a candidate for radioembolization?
It's not an individual tumor size, it's the percentage of liver replacement, and then is there a segment, much like our surgical colleagues go through, is there a segment of, quotes, healthy liver that can be preserved and protected, but not a particular tumor size?
Do you use radioembolization to totally destroy a segment of liver?
We do, and that can be done, so if a segment has no viable normal liver, and so you're wanting to do equivalent of a surgery, but doing it through the blood vessel, you can use either the non-radioactive spheres or you can use radioactive spheres. Both are very effective at destroying that distribution of the blood flow, and the side effects are not any greater than any other embolization.
Yeah, in my books, case by case, every patient are different, and also the combination of the liver metastasis are different. Some patients with just a whole bunch of small BBs everywhere, and those patients, I don't even try to resect it because no point for me to do anything. However, on the cases, I show you in my presentation, if someone with a big dominated tumor, and I know I can do this very effectively, safely, to remove it without sacrificing any healthy parenchyma, I think it's a very fair game for me to try it. And if some patient has a combination of both large tumor and small tumor, if I can find a dominant target, can they remove it safely, I take it for a couple of different thoughts. Maybe the symptom control will be better because a large tumor there producing a lot of hormone, and also make my radiation colleague have better chance to wipe out the small tumors. Big tumor, I think the bigger the target, the more difficult you get it irradiated and to get rid of it. So as a surgeon, if I can get out those tumor and without sacrifice any liver parenchyma, I will go for the resection and remove all the big dominant tumor, and then refer the patient to the interventional radiologist, to have the chemo embolization or radioembolization to treat the small BBs.
Although I should mention that nowadays, with the advent of PRRT, if somebody is already progressing on a somatostatin analog and has all of this tumor in the liver, you could make a case for using PRRT as the next modality. And we may find that some of our treatment paradigms are going to be changing over the next year or two. So just stay tuned. What are the absolute exclusions for a liver transplant, such as Ki-67, prior treatments, et cetera? Do you have criteria you could share with the group?
So we try to keep it low, Ki below 10%. Usually it's better if you have a 2 or 3 or less than 5%, because these are less aggressive tumors. Of course, you should not have metastases distant, because you're going to remove the liver and you want to attempt the cure. In terms of treatment, I think we have to be a little bit cautious. Some of those patients get a lot of chemo, radiations, and they come in with very low counts, and we're going to give immunosuppression after, so the liver doesn't reject. So I think sometimes you have to wait a little bit and have the bone marrow or the counts recover before you go for it. You should not have a major cardiac or pulmonary disease that will preclude a major operation. So the contraindications are the same as going to a major operation. If you have a good cardiovascular system, you should be okay. And you should not have metastasis distant to the site. If you have spread through the abdomen, then it's not a liver anymore. We have to change according to where your metastases are, and perhaps a multivisceral. But the absolute contraindication will be distant at this point, will be to have distant metastases in other sites that are not approachable in that operation.
Okay, why don't we start with Dr. Howe on this one? Would you remove matted mesenteric lymph nodes?
Matted? Yeah, sure, anytime it's possible. I mean, there are a couple different manifestations of this. I mean, if it's anywhere near the bowel, then taking out the segmental vessel below the SMA is okay. These aren't show some pictures of people with large matted lymph nodes around the SMA and SMB, and sometimes those are amenable to resection. Sometimes you can pop them out, but other times it's a calcified pancake of tissue that really it's not reasonable to try to do that. I think you put some patients' lives at risk because you're not going to really get on those blood vessels and see them before you cut into them. So I think some people you can, but many people, again, it's this hard calcified mass that is very difficult to remove. And you have to remember that people, even if you divide you leave those in place, those people will live a long time. So you really can't afford to lose anybody if you're going to have an aggressive approach at removing those matted nodes.
So Dr. Wang, do you have any other comments?
Sometimes, my way to approach this, I give patients, say, I will give it the best shot. I go in there to see what I can do. I dissect out the best I can. Sometimes if I cannot do it, at least I try to make a donut become a C. Like, cutting the restricting factor of the encased tumor to the mesentery vessel, and then I put my Chinese dumpling on that open C part. So hopefully it will melt away. And a few patients, I did that, and 2 years later or years later, I tried to come back to finish up, and I was amazed how much the tumor melted away. Remember, when you give it chemotherapy, 5FU, you give it 200 milligram, 400 milligram per square meter. I put 200 in square inch. So the concentration of chemotherapy I put in Chinese dumpling is overwhelmed. And the beauty about this, because the vascular blood supply already ligated when I do the surgery, I cannot let people keep bleeding. So the chemotherapy I put in there stay very locally. So don't go into the systemic circulation, don't cause any chemotherapy side effect. So that's how I treat it. I do my best, I remove all tumor. If I cannot, I at least try to convert a donut to become a C. You understand what I'm saying? So not choking the vessel, let the vessel have a chance to breathe, so to speak, so the circulation can be maintained for a while. And I put a chemotherapy Chinese dumpling in this, the trough I made and hoping for the best.
Right, so we'll have to see how that develops. Next question, are computers being used to read scans and Ki-67s? Well, the Ki-67 issue I could address. They certainly are being used. There's a technique called computer-assisted image analysis that can scan a very, very large number of cells and give an accurate determination of the Ki-67. The challenge is only for the pathologist to define the area of tumor that needs to be identified, and then you can actually get a number that's more accurate than the average pathologist is able to do, counting a small number of cells. So that is a technique that's already happening in many places. Now, I'll ask Dr. Kennedy about using computers to read scans for you.
I'm not aware of any diagnostic groups doing this similar thing as pap smears and things. So there's teleradiology where they're not physically in the hospital, but I'm not aware of computer intelligence reading body imaging.
Okay, are there any other questions from the audience that haven't come in yet? Last chance before we eat lunch. In that case, I want to thank the panel for wonderful talks and wonderful discussion, and it's time for lunch.